Hello, 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 everyone, and welcome to another edition of the Global PAD Impact Awards brought to you by the Global PAD Association. Today, I am incredibly excited to present the Global Diabetic PAD Foot Surgeon of the Year Award to a true pioneer in limb salvage medicine, Dr. Giacomo Clerici from Abano Terme, Italy. One of my favorite places, lesser known places in Italy. I love it there. Go visit. Anyway, we're bringing a little bit of Abano Terme to you today because Dr. Clerici, we got to introduce him. He's incredible. He has revolutionized the surgical management of complex diabetic and PAD foot wounds, combining exceptional technical skill with profound compassion. That compassion is so important. His innovative approaches have saved countless limbs that might otherwise have been lost to amputation. But what makes Dr. Clerici's impact truly global is his commitment to sharing his knowledge with surgeons worldwide. Through workshops and training sessions and collaborative research, he has elevated the standard of care for diabetic foot surgery across multiple continents. Patients consistently praise Dr. Clerici also for his ability to explain complex procedures in understandable terms. So he can go from clinical with all of his peers and break it all down for the patients into understandable terms. And they also appreciate them, being involved in the treatment decisions. They love the fact that he always has the conversation with them and gives them the choice. What do you want to do? Which is really empowering for them. His multidisciplinary approach ensures that vascular, orthopedic, and wound care perspectives are also integrated into every surgical plan. That is really important. So, today we're going to explore how his techniques are transforming limb preservation globally and what patients with diabetes and PAD need to know about protecting their feet and their legs. So important. Prevention is paramount. So please join me in welcoming Dr. Giacomo Clerici, our global diabetic PAD foot surgeon of the year for 2025. Congratulations, and thank you so much, Dr. Clerici, for staying up so late in Italy. I think it's 11 o'clock there at night.
Exactly. So first of all, thank you for having me here today. It's a great pleasure and honor, and I am over the moon. Believe me, I am really excited about this recognition. And so, please, I am available for any question you have for me.
What has given you a foot fetish? What makes you so passionate about limb salvage?
Well, this is a very good question. I began my career, or rather, my passion for diabetic foot exactly 30 years ago, at a time when, unfortunately, patients with diabetic foot ulcers were too often offered amputation as the only available treatment. And so, together with other colleagues, honestly, true pioneers, I would like to mention, first of all, Ezio Faglia, my mentor, my teacher, and of course, my friend, but others, Giovanni Ghirlanda, Luigi Uccioli, Alberto Piaggesi, and many others. We began to explore new approaches aimed at reducing the number of amputations, which in some hospitals at that time, I'm talking about the end of the 80s, beginning of the 90s, exceeded 50% among patients admitted with diabetic foot. And we
Wow.
didn't just, yeah, absolutely. It was terrible. And within just a few years, the amputation rate in Italy dropped dramatically, coinciding with a grow awareness of the complication known as a diabetic foot, not only among patients, but also among healthcare providers, surgeons, physicians, nurses, podologists, podiatrists, but many others.
So why is this? Why is the limb salvage and everything that's happening, why is it more important now than ever with the diabetic epidemic, leading to more PAD and foot issues? What you do is critical.
Yeah. Today, from an epidemiological perspective, the number of patients with diabetes, as you know, is increasing dramatically, particularly in certain regions such as Latin America or, for example, in the Arab countries. And inevitably, diabetes-related complications are also rising in absolute numbers. Moreover, peripheral arterial disease itself has evolved over the past 50 years, increasingly involving the arterial district of the foot, more distal than before. And all of this makes diabetic foot not only a global problem, but
Yeah.
also one of the major numerical impact.
Talk about the difference between a diabetic foot and PAD issues with the foot.
The difference lies in the fact that by diabetic foot, we refer to foot with or without ulcerations that is affected by neuropathy and or arteriopathy. Though when I speak of diabetic foot, I also include the ischemic foot, namely the one with peripheral arterial disease. However, it must be remembered that diabetes does not affect only the arteries, but also, for example, the peripheral neuropathy. We have the peripheral neuropathy. As a result, there are patients with the so-called neuropathic foot who may develop one of the most severe complications of the neuropathy, as you know, the Charcot foot. This complication, much like ischemic foot, can unfortunately lead to extreme situations requiring amputation. Unfortunately, in recent years, we have achieved remarkable progress in reconstructive surgery for Charcot foot, which has
Okay.
made it possible to reduce the amputation rate even in this patient population.
Dr. Clerici, many of our viewers are living with diabetes and PAD, often fearing amputation. What surgical innovations have you developed and or are using that are giving hope to patients who might have been told amputation was their only option?
Undoubtedly, there have been, in my opinion, three key milestones that have changed the history of the diabetic foot, and above all, the history of amputations in diabetic foot syndrome. The first was certainly the increase in the number of revascularizations. Having at our disposal a less invasive technique than peripheral bypass, namely endoluminal revascularization techniques in patients often burdened with significant comorbidities, greatly expanded the number of individuals who could benefit from revascularization. The combination of the two approaches, open techniques, namely bypass surgery, and the endovascular techniques, led to a striking shift. You have to imagine that in the 90s, in some Italian hospitals, only about 25% of patients underwent revascularization, whereas today, more than 90% of our patients with chronic limb-threatening ischemia receive it. And this is a very
Big
important
difference.
change in the last
Yeah.
30 years. And the second milestone was the implementation of loading techniques for diabetic foot ulcers, even through the use of dedicated devices or surgical approaches, for instance, in cases of severe deformity. And this step, equally as important as revascularization, is the same for neuropathic foot. Offloading is important as is important revascularization in the ischemic foot remains a crucial therapeutic intervention though unfortunately still too often is underestimated and overlooked. And the third milestone has undoubtedly been the timely treatment of sometimes surgical of the infection. In diabetic foot, time is a decisive factor in reducing the risk of amputation. As you know, time is tissue. We are used to say always time is tissue.
And time is tissue and it takes a team. And you are known for your multidisciplinary approach to limb salvage. Could you explain how collaboration between the different specialties, vascular surgeons, podiatrists, wound care experts, endocrinologists, all of the above, and you led towards it, you hinted at it, you expressed some of it, but how all of that team approach leads to better patient outcomes?
This is an important point. The answer lies in the very nature of this complication. We are not dealing with a single disease, but with a syndrome determined by two major complications of diabetes, neuropathy and arteriopathy, to which unfortunately infection is still too often superimposed. Therefore, a multidisciplinary approach is the only possible response to a syndrome with such a diverse etiopathogenesis. Generally speaking, broadly speaking, the neuropathic foot is frequently characterized by deformities where the orthopedist or podiatrist plays a central role. On the other hand, the ischemic foot results from reduced blood flow, making the vascular surgeon, endovascular surgeon, or interventional radiologist or cardiologist the key specialists. Yet, these patients frequently present with additional complications such as coronary artery disease, cerebrovascular disease, or diabetic nephropathy, or with an infection. It is, though, evident that a multidisciplinary approach is essential to improving the prognosis and the outcome of these patients.
So I want to dive just a little bit deeper because we always hear about the diabetic foot, and that's what we are, alluding to. And you talked a little bit about diabetic foot versus PAD, but what makes the foot wounds so challenging in the patients who have both diabetes and PAD, and how your surgical approach addresses these unique challenges?
The challenge with diabetic foot wounds lies in their multifactorial nature. Diabetes often causes both neuropathy, which leads to deformities, as we have just heard, and loss of protective sensation, and peripheral arterial disease, which severely limits the blood flow and healing capacity. And when infection is added, the risk of rapid deterioration and amputation increases dramatically. So my surgical approach is based on timely revascularization, of course, whenever possible, combined with offloading, infection control, and when needed, reconstructive surgery. Only by integrating these strategies can we preserve the limb and improve the long-term outcomes.
So many patients, they struggle with reoccurring foot ulcers, especially, I mean, with either one or even worse with both. What surgical interventions have you found most effective for breaking this cycle? And what can patients do to prevent wounds from returning after successful surgery? You talked about restoring the blood flow, getting, all the way down into the artery loop in the foot using wires and balloons and whatever other tools they may have at their in their toolbox, to the vascular specialist, the surgeon, to interventional radiologists, or whomever. But what's next from your perspective, from a podiatric surgery perspective?
That too, like all your questions, is an excellent one. It is well, really,
Yeah.
really. It is
Yeah.
well established that recurrences that is the development of new ulcers in a patient who has already had previous lesions represent a major challenge in diabetic foot care. Today we know, however, that with proper follow-up, the appropriate use of therapeutic footwear and insoles and the educational program involving not only the patient but also the relatives, family members, caregivers becomes essential to correct severe deformities that even specialized footwear cannot adequately protect against, thereby preventing future recurrences. So in this case, the role of surgery when you have severe deformities is really important. But in the largest part of the cases, if you have a very good follow-up program, if you are able to explain to the patients that the importance of shoes and insoles and the follow-up means to see the patients every 2 months, even without new ulcerations, you are able to reduce the recurrency rate for sure. We have demonstrated in a paper that we published many years ago in Diabetes Care that with this kind of follow-up program, with the use of appropriate footwear and shoes, we are able to reduce the new ulceration in a very large number of patients.
Very cool. And you've trained surgeons across multiple continents. Have you noticed differences in how diabetic foot care is approached on these different continents? And are there lessons from Italian healthcare, from your lab in particular, that could benefit patients worldwide if only they would get adopted?
Yes, there are differences often linked to healthcare systems and, of course, available resources. In Italy, a strong emphasis has been placed on multidisciplinary teams and earlier vascularization, which have significantly reduced the amputation rate. Don't forget, for example, that in Italy, in the decade 2001 to 2010, we have reduced the amputation rate among patients with diabetes by more than 30%. And I believe that this integrated team-based model of care is a lesson that can benefit patients worldwide.
Gosh, I wonder what the secret was to a 30% reduction in diabetes.
Yeah, yeah. In the amputation
We
rate among patients with diabetes, yes.
amputation rate among
Amputation
okay,
rate among patients,
okay,
reduction in 10 years by more than 30%. Yeah. This is
that
a nationwide analysis.
that is amazing.
Yeah.
So, could you share a particularly challenging case that transformed your approach to diabetic foot surgery? Perhaps a patient where traditional methods were not working, but your innovative techniques saved their limb.
Uh, One of the most transformative case for me involved a patient with severe infected ill ulcers. Traditionally, this type of lesions almost inevitably led to major amputations, and indeed other colleagues had already suggested it. And instead, we applied an innovative approach using, for example, antibiotic-loaded bone substitutes to control the infection and reconstruct the defect. And this strategy not only allowed us to save the limb, but also profoundly changed the way I look at possibilities for limb salvage in a complex
Yeah.
diabetic foot cases, in particular for patients with ill lesions.
So, for patients who might be facing their very first foot surgery due to diabetes or PAD complications, what should they know about recovery and rehabilitation to achieve the best possible outcome? I know that's vague. I know there are a lot of different procedures they could have, but talk in general about what is expected of the patient to be their best partner in care.
Yeah. Uh, I think that the most important message is that surgery is just one step in the journey. It's just one step. Recovery and rehabilitation require close follow-up, proper wound care, strict offloading, and sometimes tailored footwear and orthosis. And controlling blood sugar, managing vascular health, and addressing risk factors such as smoking cessation are equally essential, as you know. With a committed team and an engaged patient, I think that it is very important this point. Outcomes can be greatly improved and the risk of further complications significantly reduced.
So I know this is a little redundant. We have a few other people that are joining in just now through the stream. But again, how has the technology, whether advanced imaging or specialized instruments or new materials, really changed your surgical approach to diabetic and PAD foot wounds over the years? Basically, what are you most excited about right now?
Technology has completely reshaped our approach. Advanced imaging allow us to plan surgery with far greater precision, while specialized instruments make procedures less invasive and safer for fragile patients. As you know, they have a lot of comorbidities. And new
Mm.
biomaterials such as antibiotic load bone substitutes, dermal scaffolds have expanded the reconstructive options, allowing us to save limbs that once would have been lost. And more recently, cell-based therapies and innovative procedures like foot vein arterialization are opening further horizons, offering new hope for patients so-called no option, as you know very well.
So when it comes to these patients with diabetes and PAD, how do you determine when to attempt limb salvage surgery versus when amputation might actually be the better choice for quality of life for these patients?
Yeah, the decision is never easy,
Hard.
as you can imagine, and must be highly tailored, individualized. Whenever possible, we aim for limb salvage. We try always as revascularization, infection control, and reconstruction can offer patients both mobility and independence. However, when the limb is no longer functional, when we cannot achieve the functional limb, pain is uncontrollable, or the patient's overall condition makes reconstruction more dangerous or unsafe, amputation may provide a better quality of life. I think that the key is honest communication with the patients and a multidisciplinary evaluation to choose the path and that truly serves their well-being.
So looking to the future, what developments in diabetic foot and PA surgery are you hoping for, down the road that you want to see, come into play? There could be a dream, maybe there's still a major gap in care and technology. There could be something that is on the horizon, but it's not quite in your hands yet.
Hmm. I truly believe that in the next decade will be transformative, the next decade. With the rise of less invasive revascularization procedures,
Mm.
cell and gene therapies, innovative biomaterials, and new approaches like foot vein arterialization. Again, we are entering an era where limb salvage will become the norm rather than the exception. If we are able to combine these advances with digit technologies for early detection and patient engagement, I am convinced that we can dramatically reduce the amputation rate worldwide. The future is one of hope, not just for saving limbs, but for preserving lives and
Yeah.
independence.
So earlier you talked about a challenging case. Do you have another case that you can share with us that you learned a valuable lesson from that other physicians and clinicians can actually learn from? It could have been a success, it could have been a failure. We've had both.
One case that deeply marked me was a patient with a severe midfoot infection. Initially, despite aggressive debridement and antibiotics, the situation worsened a lot. And for a moment, it seemed we had no option but major amputation. Instead, through a team approach through talking each other, vascular intervention, reconstructive surgery, advanced wound care, etc. We managed to save the limb. And the lesson I took from this case is that uh, perseverance combined with multidisciplinary cooperation, collaboration can turn an apparent failure into success. It taught me never to give up too early, wait and see. Of course, when wait and see, it is safe, because sometimes the difference between amputation and limb salvage is simply not losing the hope.
Oh, I love that. Hope is so key, and it's not about giving false hope to patients. But all patients want is for you to give it the best try possible. And they want you to understand what even you may not know that someone else may know, and to let them get a second opinion or to have you talk to someone else about it to see if someone else has a different idea. You talked about that multidisciplinary approach. And that's all patients are asking for, that good old fashioned try.
Yeah, yeah.
So, describe a case where a patient should have been diagnosed with PAD sooner, but wasn't. And because of that, presented on deck for complex revascularization, reconstruction, or amputation. And this is really a segment to raise awareness of the delays in patient care because of patients getting misdiagnosed with just having issues due to diabetes, just having issues due to back problems, just having issues with their feet due to fibromyalgia or arthritis. Do you have a case where you're thinking, why am I getting this patient now? They should have been diagnosed sooner.
Oh, yeah. Late referral, I think that is one of the most challenging situation in our daily routine. One case that stands out is a patient with a plantar ulcer that for many months was treated as purely neuropathic wound. Actually, in reality, it was a neuroischemic ulcer, and the delayed diagnosis meant that underlying osteomyelitis developed. The patient was kept in limbo with only offloading when what was really needed was offloading, revascularization, and surgical treatment of the bone infection.
Mhm.
And by the time he I reached our team, and the case had become much more complex than it should have been, because if we have visited these patients maybe just a few months in advance, we have for sure changed the outcome of these patients. And this experience highlights the importance of not underestimating ischemia in diabetic foot ulcers. Timely recognition and combined treatment can prevent severe complications and, most importantly, save the limb.
Most importantly,
Yeah.
is save the limb. So patients love this next one because they like to hear when doctors are proud of them. So they like to hear when a doctor is proud of their patients so that they can strive to be that patient that doctors are proud of. So share the story of a patient who impressed you with their effort to improve their PAD prognosis on their own through their own methods, whether it was walking or eating better or smoking cessation or better wound care on their own. Do you have a story you can share?
I have many actually, but I remember in particular a patient with a CLTI, a chronic limb threatening ischemia, who, after a successful, very complex revascularization carried out by Marco Manzi, completely transformed his lifestyle. He
Mhm.
quit smoking, followed a strict walking program, and engaged actively in his wound care. And what impressed me most was his perseverance. He never missed the follow-up and involved his family in the process. And today he is working independently, and his determination is as important to his outcome as any surgical intervention. It reminded me that true success comes from partnership between, of course, physicians and patients and persons.
Oh, that was beautifully said. I love that. Okay, since you did mention walking is medicine, share your best motivational speech for walking as medicine. It could be analogies you've developed to explain its benefits. You could talk about collateral vessels and how they're formed. You could talk about techniques, especially with those who have wounds. Give it your best shot.
Okay, uh, every step is medicine. Walk, rest, walk again, and step by step, your legs build new vessels and build your future.
And
Did you
what
like
about
it?
I do. I love it. Every step is medicine.
Yeah,
That
for
should
sure.
be that should be the slogan. Every step is medicine.
Yeah, it's
What
like a
about for
pill.
it's like a pill. We just
Yeah,
need to put the word, we need to have little pill bottles that the pharmacist hands out. You prescribe it, and there'll be a bunch of placebos in there. And every time you walk, you get to take a pill out, a fake pill. And I'll say, walk on it. So you take it out.
we're
You
going
just
to working on it. Perfect.
we're going into business together, Dr.
Yeah, yeah.
Clerici.
Why not?
So what about for patients who are healing wounds? Do you have any suggestions for them while they're sitting and trying to heal a wound to improve their circulation? Because they have to keep moving somehow. They can't just sit on their butts all day. But it's hard to move when your foot's all wrapped up and painful.
Sorry, I lost the connection for a couple of seconds. I lost the question. I'm sorry.
It's okay. It's technology. It happens. Sounds like you have better technology for foot care than we do for a Zoom, for
Don't
a
worry.
virtual interview. Um, so when people have foot wounds, it's really hard to get up and walk at a pace or to walk in a way that you can improve your circulation, do you talk to them about foot exercises that they can do while they're sitting to improve their circulation?
Yeah, this is a very good question because in many cases, of course, to walk walking is a medicine, as we told, as we have just heard. But in many cases, these patients have an ulceration, a foot ulceration. So we have to find the balance between the two things. But when we have a foot ulceration in the largest part of the cases, we allow the patient to walk with post-operative shoes or walkers. So we can allow the patient to walk because exercise is really important, but protecting the foot or protecting your work if you carried out surgery. So of course, the exercise is really important, but in some steps of the treatment, you have to reduce this important exercise because this could change the outcomes of your wounds or your surgery.
So that was great. So share a defining moment. I should have asked you this earlier, but I'm really curious. I want to hear, I know that you talked a little bit about it first, that your foot fetish. But was there an actual defining moment in your career that we would call the 6 minutes that matter? That inflection point, it could have been a conversation, it could have been a scene in a movie or a documentary you watched, or a moment with, you had mentioned a mentor, something you observed, something with a patient where you said, oh my gosh, and you made a big shift in your career or in your treatment or how you handle patients based on this moment.
For me, I think that the defining moment came very early in my career. When I witnessed, sorry, a young woman, a young lady with diabetes lose her leg to an amputation that may have been avoided with timely treatment of the infection. She was infected, severely infected, and because of the late referral. I still remember her face, the sense of loss, and the impact it had on her entire family. In that moment, I promised myself that I would dedicate my work to finding better ways to save the limbs and lives, and I started to improve my knowledge about the diabetic foot. And that experience has guided every decision since, and it continues to remind me why perseverance and innovation matter in this field.
Yeah. So I have one final question for you. I may have a bonus question if you're up for it afterwards. I just started asking people. It's a little funny, but let me ask you this one first. A moment with a patient that still has you shaking your head, something patients can learn from. Mistakes happen, patients make them, but they can learn from them. It can even be I can't believe a PAD patient just said this or did that. And it's not to make fun of the patient. It's that they're lessons that we can all learn from because everyone is on a different journey.
I will never forget a patient with peripheral arterial disease, PAD, who continued to smoke even after a revascularization. When I explained that each cigarette was undoing the surgery he had just performed, He looked at me and said, "But doctor, I only smoke when I am stressed." And that moment, and me shaking my head. And the lesson for patients is simple. Even a few cigarettes can destroy the success of the treatment.
Yeah.
Quitting truly means saving your life and your legs.
I might add another question there. You bring up a really good point about smoking, and we always talk about how the smoking actually inhibits, it prevents wounds from healing. And patients don't understand the mechanism of action by which that happens. And I only know the one is that it prevents oxygen from traveling in the blood to the wound, right?
Yeah, absolutely. Smoke is not dangerous for arteries in terms of atherosclerosis, etc. It has been demonstrated that reduce the healing rate. There are some papers that demonstrated that you have a reduced healing rate if you are a smoker, because of course there is a reduction in the oxygen. There is also an obstacle to the wound healing because it damages many cells, many growth factors, etc. Absolutely.
Thank you for that. We have our smoking cessation weekly meeting in just a couple of hours. So I'm going to share that because I think it'll be really helpful. Okay,
Absolutely.
one fun bonus question. You can choose not to answer it. It's kind of a weird one, but I started asking it a few days ago because I used to work as a journalist, and there was a blog called Pando Daily. And one of the girls that worked there had a question that she liked to ask all of the entrepreneurs. And it was kind of a funny question with funny answers. And if someone asked you what if you could have any superpower, what would it be? And you would say flying, being invisible, walking through walls, things like that, right? But what if I was to ask you what it would be your mediocre superpower, a not so cool superpower? And what I mean by this is think of something in your everyday that annoys you, that you can't believe, oh my goodness, not again. And you wished you could go poof and it would be done, or that it wouldn't happen. I can give you a few examples.
Please.
Okay. So, generic examples, one entrepreneur said that her mediocre superpower would be that when she got out of the shower, she wouldn't be cold. She didn't want to be cold at all when she turned off the hot water, even for a moment. That would be her mediocre superpower. A gentleman said this one. He said he wished he could remove his arm safely while spooning with his wife so his arm wouldn't go numb and both could remain comfortable. We
Mm.
had a doctor actually say, in asking this, that every morning as he's driving into the OR, he would get the call from the nurse every morning, never fails. Which way do you want the patient? Which end is up? Which end is which way? And he almost wished that he could be telepathic and just they would know automatically. So they wouldn't have to call him every single morning to ask him the same question.
Wow. Wow. Honestly, in this moment, I don't
It's a tough
know.
one, right? That's a tough one. I'm
I,
wondering if there was anything, would be a really cool mediocre superpower if there was anything else other than a maggot that could clean those wounds so squeaky clean. If there was something less squirmy.
I think that I have a lot of these these thoughts every morning, but I have to choose one very particular. So give me time. I will send you an email, and the next online in the next live, I will give you the answer.
That I told you it was a tough one. We just started asking people that question. It's kind of a cool question. It could even
Yeah.
be that, you wish that you could snap your fingers and the documentation for every patient would be done. And that is soon to be with AI. So that's a true mediocre superpower that's gonna come to be.
Honestly, this could be a very good one because if you think that today we use 80% of our time for bureaucracy and 20% of the time for patients, with just a snap, I would like to change this one. Should be amazing. Should be amazing. 80% for treating patients and 20% for bureaucracy would be perfect.
See, you nailed it. Perfect mediocre superpower, but I think it's a mediocre superpower, and we'd all love to
Yes.
see that.
Yes,
But
for
thank you
sure.
for putting that out in the universe. So thank you so much. Congratulations,
Yeah.
Dr. Giacomo Clerici, Global Diabetic PAD Foot Surgeon of the Year award winner, a true pioneer in limb salvage medicine. Thank you for all you do to save life and limb.
Thank you for having